Hello, my name is Uwe Platzbecker. I'm head of Department of Hematology and Cellular Therapy at the University Hospital of Leipzig in Germany. MDS and AML are a disease of the elderly, and we know that age is also associated with a state of inflammation. So inflammation in the bone marrow, in the microenvironment, in the osteohematopoietic niche is very common. And this inflammation is driven by several players. Also, it is known that certain proteins are actually overexpressed or activated, driving this inflammatory process, like IRAK4, like MyD88, IRAK1, and others. And this is also driven by the overactivation and overexpression of receptors on the cell surface of these progenitor cells, mainly toll-like receptors and their respective ligands. This is also associated with the generation of reactive oxygen species, TGF-beta, and other cytokines, which, with an autocrine loop, also foster this inflammatory process in the bone marrow. However, the progenitor cell is not alone in the bone marrow. As we know, it's embedded into a microenvironment, into the so-called osteohematopoietic niche, and also this tight interaction, but also aberrant interaction, very much drives the immune dysfunction in MDS and AML. We also know that there is an immune dysfunction in MDS and AML because under physiological conditions, immune cells within the microenvironment in the bone marrow are basically able to eliminate hematopoietic stem and progenitor cells, leukemic cells, so to eliminate aberrant cells on a daily basis. In MDS and AML, and also during cancer progression, changes in the local milieu, also inflammatory changes, affect the phenotype of surrounding cells, and this may then also inhibit the effective immune responses against the pre-malignant or malignant clone. So what we know is that this very, very diligent balance of the cells in the bone marrow is significantly disturbed very early at the time of the disease. There are plenty of reports that it's not only a single cell being involved into this perturbation. We have evidence that during disease progression from MDS, numbers of immunosuppressant cells like myeloid-derived suppressor cells, MDSCs, or regulatory T cells actually increase. And on the other side, there's a reduced T cell proliferation and activation, which with deficits also in pro-inflammatory cytokines, induction of cytotoxicity, overexpression of inhibitory immune checkpoints like PD-1, but also upregulation of PD-L1 actually on the surface of cancer cells, namely blast cells. And this contributes significantly to the disease progression and also to the development of refractory disease in these patients. There are actually plenty of overexpressed targets, and I think some of them are already targeted in the clinic, and some of these agents are already pretty advanced. I would start with TIM3, which is a T-cell immunoglobulin mucin domain containing protein 3. It marks the most dysfunctional or terminally exhausted T cells, inhibiting macrophages, NK cells, and dendritic cells. And it's not only expressed on the T and immune cell compartment, it is also expressed on the aberrant progenitor and stem cells, with the significant overexpression in high-risk MDS and AML compared to the counterparts, to the normal counterparts. So this TIM3 is also therefore an attractive target, not only of the imbalanced immune part of the bone marrow, but also targeting the progenitor cell itself. LAG3 stands for lymphocyte activation gene 3. It's used as a T cell activation marker for both CD4 and CD8 cells, and blocking LAG3 also can mitigate Treg function. Then we have TIGIT, which stands for T cell immune receptor with Ig and ITAM domains. It's expressed on activated T cells, Tregs, and K cells, and this high expression is also associated with poor clinical outcome in AML. It is currently also in combination with PD-1 blockade in advanced myeloid malignancies. And then we have CD47, which is the so-called don't eat me signal, expressed on cell surface to prevent phagocytosis by macrophages via binding to signal regulatory protein alpha. It is also a prognostic marker in AML patients. So overexpression confers a poor prognosis and is currently already targeted in advanced clinical trials.
I'm Agnieszka Wierzbowska, and I am a hematologist from Medical University of Lodz, Poland. And I'm happy to be with you today discussing some issues related to novel immune-based approaches in MDS and AML. Current knowledge suggests that in MDS as well as in AML, malignant cells could transduce the surrounding bone marrow microenvironment into a leukemia supportive niche. And many pathways are used by leukemic blasts to evade immune surveillance and promote disease progression. Immune checkpoint molecules play important roles in maintaining an immunosuppressive tumor microenvironment, and recent studies have demonstrated overexpression of programmed cell death 1, so-called PD-1, by effector T cells and Tregs. On the other hand, programmed cell death ligand 1, PDL1, was mainly upregulated in CD34 positive blasts. There is evidence that PDL1 positive blasts isolated from MDS patients exhibited a growth advantage compared with PDL1 negative blasts. Moreover, dysregulated PD-1/PDL1 signaling was responsible for ineffective hematopoiesis, which is one of the hallmarks of MDS. Furthermore, studies showed that PDL1 positive blasts from MDS-AML patients had a higher resistance to T-cell mediated killing. And many factors are implicated in dysregulated PD-1/PDL1 signaling in AML and MDS, including abnormal inflammatory signaling, genetic mutations or epigenetic alterations, as well as cell-cell interactions. Moreover, a correlation between dysregulated PD-1/PDL1 signaling and resistance to hypomethylating agents has been identified. It's also worth mentioning that other immune checkpoints, such as CTLA-4 or TIM3, have been shown to be upregulated in patients with MDS and AML. Feasibility and safety of immune checkpoint inhibitors targeting PD-1, such as nivolumab or pembrolizumab, or PDL1 like atezolizumab, or CTLA-4 like ipilimumab, are currently being explored in early phase clinical trials. Pembrolizumab monotherapy was examined in a phase 1b study which enrolled 28 MDS patients who failed hypomethylating agent therapy. The overall response rate was only 4% with an overall survival rate of 49% at week 24. The efficacy of nivolumab was evaluated in a phase 2 trial, which included 15 MDS patients following hypomethylating agents failure. And no CR was detected, and only 2 patients achieved partial response, leading to overall response rate of 13%. And the median overall survival was 8 months. Although the efficacy of anti-PD-1 antibodies used as monotherapy was unimpressive in hypomethylating agents failure cohorts, their safety profile was generally favorable in these trials and no treatment-related deaths were reported. However, a phase 1b trial on atezolizumab, the only anti-PD-L1 antibody that was examined as monotherapy in MDS patients following hypomethylating agents failure, reported that 70% of patients did not survive after a 160-day median follow-up, mainly due to disease progression. And in the next phase 1b study, 29 patients with higher risk MDS who have failed hypomethylating agents received ipilimumab monotherapy at 2 dose levels with an induction followed by a maintenance phase. And best responses included marrow complete response in 1 patient, but prolonged stable disease for longer than 46 weeks occurred in 7 patients that make up 24% of the entire cohort. And interestingly, 5 patients underwent allogeneic stem cell transplantation without any excessive toxicity. In conclusion, although preclinical studies suggested potential benefits of PD-1, PD-L1 blockers for MDS and AML, especially after hypomethylating agents failure, current clinical outcomes after applying such agents as monotherapy were disappointing. Preclinical investigations suggested potential synergistic effect of hypomethylating agents and PD-1, PD-L1 inhibitors, as the hypomethylating agents have shown to upregulate PD-1, PD-L1 axis, potentially making immune checkpoint inhibitors more effective. And clinical trials have studied this combination with mixed results, with data mostly unimpressive in hypomethylating failure and relapse refractory patients. In basket exploratory phase 2 study, 20 patients with MDS were treatment naive and were treated with nivolumab and azacitidine. And 21 patients received ipilimumab and azacitidine. And the overall response rate was 75 and 71% respectively for nivolumab and ipilimumab arm, with pretty encouraging composite complete remission rate, 50 and 38% respectively. And it's worth mentioning that the median overall survival in ipilimumab arm was not reached, but the safety profile in the both arms was comparable. In the phase 2 study, evaluating efficacy and safety of pembrolizumab and azacitidine in 37 MDS patients with IPSS intermediate 1 or higher risk disease, the overall response rate was 76% in HMA naive cohort and 25% in the HMA failure cohort, with a complete remission rate 18 and 5% respectively. In another phase 2 study, including 70 relapsed refractory AML patients treated with azacitidine and nivolumab, the overall response rate was 33% and was higher in HMA naive than the HMA failure group, but the composite complete remission rate was 22%. Sintilimab is another anti-PD-1 immune checkpoint inhibitor, which efficacy and safety in combination with decitabine was evaluated in 52 higher risk MDS patients, 21 of them being hypomethylating agents naive. The overall response rate was 62%, including 29 complete remissions, 19% of marrow complete remission, and 14% of marrow complete remissions with hematological improvement. The treatment was well tolerated, there was no grade 4 adverse events, and the most common grade 3 adverse events observed in more than 10% of patients were febrile neutropenia and pulmonary infection. About 50% of patients experienced and immune-related adverse events, but all were resolved with corticosteroids. In another phase 1b trial, the PD-L1 inhibitor atezolizumab combined with azacitidine was evaluated in 32 high-risk MDS patients. And although a relatively high response was reported in the HMA naive cohort, with the overall response rate of 62% and CR rate of 14%, an unexpected early mortality was noted. And it was reported that 29% of patients did not survive within 3 months after therapy initiation due to serious treatment-related adverse event. And this unexpected early mortality rate led to early termination of the study. Recently, results of 2 randomized phase 2 studies on PD-L1 inhibition therapy for treatment-naive, higher-risk MDS patients and AML patients have been published. In these studies, a total of 84 high-risk MDS and 129 older AML patients were randomly assigned to receive either PD-L1 inhibitor durvalumab in combination with azacitidine or azacitidine alone. Grade 3 and 4 hematologic adverse events were reported more frequently in combination arms, azacitidine plus durvalumab, as compared to azacitidine alone. The overall response rate in MDS group was 62% and was higher than in AML patients. But these studies showed that azacitidine combined with the durvalumab was feasible, but provide neither response nor survival advantages over azacitidine alone, both in high-risk MDS patients and AML. Intensive chemotherapy was also suggested to exert synergistic effect with PD-1, PDH1 treatment. And in a phase 2 trial, 37 relapsed refractory patients were administered with high-dose cytarabine in combination with pembrolizumab, with overall response rate 46% and CR rate 38%. And what's important, the grade 3 immune-related adverse reactions were rare and self-limiting. In another phase 2 study, 44 patients treatment naive, including 42 AML and 2 high-risk patients, were treated with 7+3 induction in combination with nivolumab, and the overall response rate was 80%, 78% achieved complete remission, but no significant improvement compared to a contemporary cohort was observed with regard to overall survival. The factors accounting for these mixed responses are not completely understood, and reasonable explanation may include, for example, the genetic heterogeneity. It is well known that MDS and AML are highly heterogeneous diseases with multiple driving mutation and clonality, which drive genetic diversity even within the same risk group. So there is evidence that patients who carry specific somatic mutations, including P53, TET2, SRSF2, and the others, are more likely to respond to PD-1, PD-L1 inhibitors. Levels of expression of PD-1 and PD-L1 or CTLA-4 can also impact response to immune checkpoint inhibitor. Patients with low levels of these immune checkpoints will probably not respond as well as those with the high levels. Furthermore, the T-cell regulation is an extremely complex process involving multiple inhibitory checkpoint molecules. So PD-1 upregulation is frequently accompanied by the co-expression of other immune checkpoints on effector T cells, including TIM, LAC, CTLA4, and others. And additionally, peripheral blood cytopenia, pretty common in MDS patients, with decreased number of functional effector T cells, as well as lower mutational burden in AML compared to other cancers offering less leukemia-specific antigens that can be recognized by T cells, could be an additional potential reasons. So finally, most of the trials mentioned above are not randomized studies with inadequate sample size. The randomized trials with larger sample size across different patient populations with longer follow-up should be required in the future.
Hi, my name is Valeria Santini. I'm an associate professor of hematology, and I'm chairing the MDS unit in the hospital in Florence, that is the University of Florence teaching hospital. TIM3 is a very interesting target because TIM3 is highly expressed both on leukemic cells and in immune cells, NK and T helper cells, with, of course, different significance, biological significance. So if we block TIM3, there is an inhibition of the proliferation of leukemic cells because it blocks the TIM3 galectin-9 autocrine feedback loop. So if we give anti-TIM3 agents, these are stimulating apoptosis of leukemic cells, and at the same time they are active on T helper cells that are exhausted and overexpressing TIM3, and at the same time they stimulate phagocytosis, and they also stimulate the activity of both T cells and NK cells. This is why having this dual function, anti-TIM3 antibodies can be very interesting in the treatment of diseases like myelodysplastic syndromes. Sabatolimab is in fact a first-in-class high-affinity humanized IgG4 antibody that targets TIM3. There have been quite interesting data. The results, in fact, of the phase 1b study that was combining sabatolimab with hypomethylating agents in patients with very high risk or high risk myelodysplastic syndromes according to IPSS-R and MD-AML have indicated that this drug can be very successful in the treatment of these patients. So, for instance, 53 patients with very high risk and high risk MDS have been treated with this combination with both sabatolimab and decitabine, sabatolimab and azacitidine. The overall response rate was nearly 57%, and the interesting data were regarding CR rate, more than 19%. With a marrow CR rate also very high, but especially the duration of these responses, 17 months, was quite interesting. The duration being one of the most important unmet needs that we have in the treatment of MDS and AML. As you may see, around 40 patients were treated with AML, were treated with sabatolimab and in combination. The overall response rate was 42.5%. And again, here we have quite a high number of patients, a quarter of them, that achieved CR. Median duration of response was exceeding 1 year. And the estimated overall progression-free survival at 1 year was more than 25%. So this study is also highlighting the fact that sabatolimab is very well tolerated. The safety of the drug is good, and it doesn't seem to add toxicity to the mild toxicity we know that is caused by hypomethylating agents. There are many trials then ongoing with sabatolimab. So we still have to see the results, and we are very eager to verify, especially in patients with very high-risk MDS and ELN adverse risk AML, whether we can achieve response and long duration of response. CD47 is a transmembrane protein that is expressed in leukemic cells and in dysplastic blast, and it's a ligand for SIRP-alpha. Now, the activation of this receptor triggers a signal transduction that blocks phagocytosis. Therefore, if we target CD47 and SIRP-alpha interaction, we may be able to restore phagocytosis. CD47 is, let's say, thought as an do not eat me signal. This do not eat signal avoids the phagocytosis of leukemic blast, and therefore inhibiting it and blocking it with an antibody should really help hypomethylating agents, that are the agents that are frequently coupled with CD47 antibody, to eliminate the blast from the bone marrow. Magrolimab is the first anti-CD47 antibody that has been evaluated in clinical trials. The phase 1b study was showing a good safety and tolerability of the drug combined to azacitidine. So in 95 patients with high-risk MDS, the overall response rate was 74.7%. So this is very promising, with a CR rate this exceeding 30%. So I would say that the achievement of these results are really indeed indicating the activity of magrolimab. The median duration of response is around 9 months, and the median overall survival, because the drug is still under evaluation and the study is still ongoing, was not reached. There were some adverse events, though, like anemia. There is an hemolytic anemia, not immune, but because of phagocytosis. And this was the reason why the study was kept on hold for a while. But then, when this safety issue was cleared, the study started again. So we are eager to know what the results will be, because again, magrolimab seemed to be very active also in patients who have adverse features of the disease, like TP53 mutation and complex karyotype. So we are expecting to see the results also in MD-AML patients, because in this patient, the naive population achieved in 65% of cases a good response, whereas in the expansion cohort of untreated but TP53 mutated patients, there was a 48% of response rate. And again, median duration of response, especially in this very critical subset of patients, was exceeding 8 months. So we are conscious that this is a new drug and a novel approach that may really help patients who have otherwise a very poor prognosis to achieve a longer duration of response. In addition to what I said, are the study design that include a triplet. Now, venetoclax is an anti-BCL2 agent that is in use, and it has been approved for treatment of AML. The association of magrolimab azacitidine with venetoclax is the object of the phase 2 study, and the patients with newly diagnosed AML, high-risk AML, or relapsed refractory AML, who are older or unfit to receive chemotherapy. Now, only a few patients are available at the moment, but the overall response rate was extremely promising because all of them responded. In one patient only was lost because of death after 3.4 months, but the majority of patients are still on protocol, and we are therefore looking forward to see the final results. There are multiple immune therapeutic strategies that are under development in this moment, because the investigation is broadening the panorama of agents that could be eliciting an immune response in MDS and AML. So immunotherapy is thought for to target the inflammasome that we know is at the basis of progression of MDS to higher risk MDS, or even to the maintenance of lower risk MDS with cytopenia. Targeting toll-like receptor is also a new approach, a novel approach, as well as eliciting NK cell function. CAR T cells have always been, let's say, at the horizon, not yet developed, but indeed there are studies underway to develop adoptive T cell transfer also for myeloid malignancies. And finally, what we knew since a long time, but has never been developed broadly for myelodysplastic syndromes and AML, is the tumor-specific T cells stimulation with vaccination. So I think that in the next few months and possibly years, we will see very interesting development of immune therapy in myeloid disease.
Hello, everybody. My name is Uwe Platzbecker. I'm head of Department of Hematology and Cellular Therapy at the University Hospital Leipzig in Germany. And it is indeed my great pleasure to welcome you to this short discussion where we like 10 to maximum 15 minutes covering novel immune-based approaches in the management of patients with predominantly higher risk MDS and AML. I'm very delighted to be joined by two very prominent colleagues of mine for the discussion.
My name is Agnieszka Wierzbowska. I'm the head of the Department of Hematology and Bone Marrow Transplantation of Medical University of Lodz. And I'm very happy to be here with you.
Valeria?
Hello, good afternoon. My name is Valeria Santini. I'm chairing the MDS unit at the University of Florence Hospital. And I'm also chairing the MDS group, the Italian MDS group.
So thanks for joining us. And I think while attending the individual interviews, you have realized that we have reviewed the pathophysiology of MDS and AML in terms of immune dysregulation and also potential different immune-based approaches being currently investigated for the treatment of our patients with MDS and AML. What we are going to do in the next couple of minutes is in a kind of panel discussion to discuss the potential impact of emerging immunotherapies on the treatment and management of our patients. Just as a short introduction, the recent EHA meeting, but also recent publications in leukemia and blood have shown you updates on the ELN, but also WHO classification for patients with MDS and AML. And most of these updates actually were driven by the novelty and the knowledge gained in the last couple of years with regards to the biology of the disease, which I think made us better reflect that at least in part, MDS, high-risk MDS and AML may be considered a disease continuum, and therefore the biology, the pathophysiology has some shared commonalities, which may be also the driver for the development of novel therapeutic agents. And I think this is what we would like to discuss. And I may start with Valeria. Valeria, what do you think about the unmet medical needs for the currently available treatment options for patients with high-risk MDS and AML? Are there any, or is everything actually satisfying for our patients?
I wish it could be satisfying. In fact, both high-risk MDS and AML do have indeed good therapies, but not enough as we would like to have. In simple words, especially for elderly AML and high-risk MDS, we do have drugs that, like hypomethylating agents, that can achieve a response or a hematological improvement, so improvement of counts, but unfortunately this improvement is not long-lasting. So I think that the real unmet need is to consolidate these responses, improve them in the patients who have a worse phenotype like the TP53 mutated ones, and especially have long duration of response. This is really something we need, and this could allow more patients to undergo hematopoietic stem cell transplant.
So Agnieszka, we have recently, at least in the European Union, but of course also FDA-based, we had a lot of approvals for AML. Why is that not the case for high-risk MDS? Is there a simple explanation? Because there are a lot of commonalities, as we pointed out. What is your perspective on that?
So absolutely, particularly for older elderly patients with acute leukemia, there has been a significant progress during the last 2 years with the approval of venetoclax, who was a game changer for elderly unfit AML patients and allowed to achieve the higher response rate. But still, we are lacking the data regarding this new agents and venetoclax for MDS patients, and the clinical study evaluating its role for MDS patients is still recruiting the patients. But in fact, it may be a bit different biology. It may be also a bit different, I would say, proliferation rate, which may influence the a bit worse results in higher risk MDS patients with the same treatment options as which are used for acute myeloid leukemia patients. Although, as a contrary, I would like to mention also the study of the patients fit for intensive chemotherapy. The results also from the CPX351. Which were pretty encouraging also for higher risk MDS patients. So I suppose we have to wait for the results of the phase 3 studies confirming the real value of novel therapies also for MDS patients.
Yeah, thank you very much. I think you raised both very important points, and also the recent changes or suggested changes in the WHO classification highlighted, but also the other classification suggestion, I think, highlighted that the biology may be the driver of the disease, and therefore I think we also should go for, if clinically indicated and also makes sense from the biology, we should go for common trials across sometimes artificial blast thresholds, like for instance, for TP53 mutated MDS and AML. I think patients should have the opportunity to enter such a trial, irrespective of blast counts, of course, beyond a certain blast threshold, which makes them into high risk. I think this is probably the future and has maybe also prevented in the past the approval of certain agents in both entities. So, Agnieszka, since you gave a very nice presentation on checkpoint inhibitors, I may take the advantage and ask you, why don't they work in high-risk MDS and AML on a, let's say, flat rate basis? I mean, there are case reports, there are also small studies, also after transplantation, but I think we were rather disappointed compared to solid cancer patients where, and also Hodgkin lymphoma, so hematology. Why is that the case? Didn't we select the right patients, or what is your perspective on that?
So I suppose that it mainly relates to the also very complicated and very different biology of high-risk MDS patients, and particularly AML patients. That's a very heterogeneous genetically disease. So we are not treating the one clone of the disease, and the expression of the immune checkpoints on the surface of different subclones may be different. Of course, there are some promising data regarding the newer PD-1 inhibitor, sintilimab, but in fact, we do not have the results of the randomized studies with the PD-1 inhibitors or CTLA-4 inhibitors, having just more or less promising phase 1-2 studies. Unfortunately, I could say that, of course, the results of the clinical studies indicate that anti-PD-L1 therapy may be of limited value in AML. Two randomized studies failed to confirm any clinical activities. Another important issue which is worth mentioning is also the toxicity of this treatment in AML, because the efficacy of immune checkpoint inhibitors in AML also may be limited in part by high-grade toxicity, particularly immune-related toxicity. And in earlier studies, it was also very nice analysis of prospectively collected data. This data showed that about 12 to 15% of patients, AML patients treated with immune checkpoint inhibitors, have severe immune-related adverse reactions, particularly pneumonitis, but also about half of them dies because of this pneumonitis. So we probably also have to learn how to manage this immune-related adverse complications in AML patients.
Thanks a lot. And I think also as you point out, the jury is still out, which patient cohort, which subset, not only with regards to disease biology, but maybe also patient characteristics, also comorbidities, may tolerate and also benefit. The situation is a little bit different, Valeria, with regards to agents like sabatolimab and magrolimab. Both agents, for instance, have entered already phase 2, phase 3 programs. What do you see? Is the future bright for these agents, or is it an all-comer strategy, or is there a biomarker maybe needed to predict the response?
Well, both the type of therapies you mentioned, the sabatolimab anti-TIM3 and magrolimab anti-CD47, are two very interesting approaches. And the studies have been designed in combination with these agents in combination with hypomethylating agents. The future is quite bright in the sense that both drugs are well tolerated, but mostly they are active in several subtypes of patients with markers or without markers. So you do not have to specifically select patients, but at the same time, you may deliver a very effective therapy in patients who have poor prognostic features. Again, complex karyotype or TP53 mutation. So I think that the immune mechanism that they elicit are prone to render both drugs very active in all subtypes of AML and MDS, which is quite interesting, together with a good safety of both drugs. So we have to learn how to use this drug, whether together at the same time with hypomethylating agents or in sequence before and after transplant. I think we still have to learn much from the results we will see soon in the phase 3 trials and in the long-term phase 2 trials. I think it's a very interesting and different approach.
Thank you both for your assessment. I think just as a short summary, you have hopefully learned that the future, I think, is rather bright with regards to the novel therapies currently being in development. We still need to understand which subgroup of patients, high-risk MDS or AML, may benefit from which certain treatment, also with regards to molecular, but also immune texture in the bone marrow or peripheral blood of these patients. I think, therefore, translational research should be accompanying these pivotal trials currently running all over the world. But I think you hopefully gathered our enthusiasm that a lot of things are currently ongoing, and we are still very much confident that in the next couple of years, novel therapies in the immunotherapeutic segment will be approved for our patients. With that, thanks for listening to our little interview here. I would like to thank Agnieszka and Valeria for their excellent comments and discussion points, and I thank you for your attention. Thank you very much.
Thank you.
Thank you very much.